Yeah, my name is Brian Callaghan. I'm a professor at the University of Michigan. I'm a neuromuscular physician here, and I'm the chair of the Health Services Research Subcommittee at the American Academy of Neurology. Yeah, I mean, it's not a easy question to answer because it's a lot of things. But how I generally talk about it is everybody knows that we need new medicines, new cures for treatments for diseases, and a lot of that goes into our basic science where we discover new things, and then traditional clinical research where we test those things. But health services is more focused on trying to maximize what we already know, and help patients with the knowledge that we've generated over the last many decades and years. And so, and we know that the current system is not perfect. So there's lots of room to improve patients' care based on what we already know that we're not doing. So I think that in a nutshell is the big picture for health services. That's a good question. So a career in health services usually starts with training like any other specialty. So, our basic scientists get PhDs. The health services researchers get PhDs or masters is even more common. A master's in health services research, or in I have one in clinical research design and biostatistics. So there's a lot of statistics involved. There are clinical scholar programs at Yale and Penn, Michigan, and UCLA that are really focused on health services research as a master's. So it really starts out with that level of training. And then, it's not unlike other research where, a lot of us get K23 awards, apply for R01 awards, and try to do major projects to move the field forward. So there's a lot of parallels to basic science and traditional clinical research. One of the differences is that we tend to not require a big lab like a basic scientist, but we require working with people that like data analysts, biostatisticians, people that know how to interpret large data. That's much more valuable to us, or part of our team, compared to traditional epidemiology. Is more research coordinators and project managers and things like that, whereas ours is more involved in data. Yeah, I mean, I think that there's lots of benefits. I'm the associate program director for research at the University of Michigan. And so I'm always trying to help the residents with their research projects. Turns out health services research is great for those kind of projects because a lot of times you can do interesting things with pre-existing data sets, so a little more manageable for residents. That's also true of other clinicians. I know our chair and a lot of chairs are interested in their clinicians doing academic projects. And they can partner with health services researchers to answer questions that they have. So they have a good question and they partner with people like me that have the research design and biostatistical expertise and data access to try to answer those questions. And so those are two ways in which I think that health services can be super valuable. We also get very large grants, and those grants come with the same indirects as the basic scientists. But we have much lower overhead than they do. They have, big lab spaces and personnel, and, our costs are a lot lower. So, it can be quite profitable to academic divisions or departments to have health services researchers that are grant funded. Yeah, well, I would say that health services is the use of data. Is a really kind of a fundamental piece to health services research, and there's a lot of questions that the leadership in the department might have, and rather than basing it on gestalt or what expert opinion, we can go into the data. So that could be the data from our patients at our health center, the data from our department. But being data oriented and biostatistically based, can help us answer questions that are relevant not only for neurology overall, which we often do for the American Academy of Neurology, but also for that are department specific as well. Yeah, I mean that's a good question. It kind of depends. I mean, if there's already health services researchers there, then partnering with them can be helpful. If there are not, and people are interested, they could partner at other institutions, or they could start a career by getting master's level training That's usually kind of, the start of being able to do things a little more independently. So it kind of depends on if they're wanting to partner or they're wanting to start an independent career. Yeah, well, this gets back a little bit to the definition. Health services research is a lot of different things, and so, some of the maybe the four big things that I think we try to tackle. We try to tackle: are we appropriately utilizing current tests, treatments, and other things for our patients? And we're able to track that and look at that. We're also interested in, whether these things are cost effective. And so we're, one of the few areas where we really focus on cost. We don't avoid the cost conversation. We embrace it. We look into it. We want to make sure that, the things that we are doing are cost effective, or at least we understand what the costs and the implications of those costs. And we're also interested in implementation. So implementation is, again, taking what we already know and then trying to actually make it happen in practice. So an example could be, we know that TPA is good for stroke, but maybe it's underutilized. And so an implementation project could be, trying to increase TPA utilization to near or close to all the people that are eligible. And then the fourth one would be, healthcare disparities, and looking at, tracking, and trying to improve the healthcare disparities that we know exist and can exist based on race, ethnicity, sex, and other factors. And so, I think those are the main goals of health services research, is addressing appropriate utilization, cost effectiveness, implementation, and healthcare disparities. Yeah, well, I mean, I think we all want, kind of gets back to the goals. We all want appropriate utilization. We want to do more of the things that we should do and less of the things we shouldn't. That makes for a more efficient healthcare system. It makes for a better patient experience, and obviously the financial aspect as well. That gets to the cost effectiveness. If we're the more we have cost effective treatments, that's better for the healthcare system. That's better for, allowing us to spend our money on new therapies that come out, and also prevent some of the financial hardships that happen to patients. Implementation, can lead to, improved use of the knowledge that we already have to improve patient outcomes. That's really the goal. And then, of course, healthcare disparities, we don't want a healthcare system, where there are major differences based on factors, such as race, ethnicity, and sex, and other things. And so, the ability to identify those and figure out creative ways to lessen and hopefully make them disappear is really what can happen with health services. And a lot of these things have advocacy and policy related aspects to them. So we're frequently working with the American Academy of Neurology to, identify, things that affect neurologists, and then advocating on behalf of neurologists based on the data that we find. And so rather than, going to Congress and asking them to support us because, this is something we believe, we try to provide them with, data that supports our opinions, and that's much more effective.